Let's dive into the topic of preparing for DBS surgery. Can you talk about the factors involved in choosing a site or a clinic at which a person will have DBS surgery, and maybe also about the providers that should be considered when you're thinking about where you might want to go? I guess there's a surgeon, maybe your movement disorder specialist or neurologist should be
Sure.
involved, and a programmer maybe. Anyway, can you just talk a little bit about that process? How does somebody choose where they're going to go?
Right. And I think the way you phrase it is correctly is that, DBS shouldn't be considered as a one and done, but it is a process, right? And it does require an entire team. And as much as I would like to think that the surgeon is the most important part of the team, that's not necessarily the case, and that everybody plays their role. So I think first and foremost, in that choice, everybody has to be comfortable with the members of that team and feel like they are responsive and they get along well because there's going to be uh, multiple steps through this process. So that definitely involves a neurosurgeon that would be involved in implanting the device. It involves a movement disorder specialist. So that may or may not be the first person that is brought up deep brain stimulation. Sometimes that is the case. Sometimes, a primary neurologist or a family practice physician will refer to a movement disorder specialist. And that movement disorder specialist, as we'll talk about a little bit more later, is critical because they are typically the ones that are going to be doing the programming of the device and adjustment post-operatively. The assistants that I have in the operating room, whether that's a resident or a fellow, the nursing staff, the scrub technician or the scrub nurse, the circulating nurse, and then the whole anesthesia team and their whole cohort, as well as the pre and post-operative nurses that help take care of you. So there's a ton of people involved, right? And so I think when we talk about choosing a center, the first step is, hey, make sure you're comfortable with the people involved. But I think the next obvious thing is to look for a center that has experience and volume. If you have a team that is doing a procedure 2, 3 times a year, there's only a certain degree of familiarity that all those team members are going to have with that procedure. Versus if you are doing that on a weekly basis, well, everybody in that team knows their role. They know the next step coming. They know how to prepare. You have more than one person that is keeping eyes on, hey, is this going the way that we expected going? And how can we make this go the way it should? The last part is, as I was alluding to, the the equally important member of the team is that programming neurologist because long-term outcomes are driven by two primary things: electrode location and programming expertise. There are a number of studies that show that the expertise of a programmer absolutely matters. One study showed that when patients went from an inexperienced programmer to experienced programmers, their motor improvement score, their UPDRS-3, went up by 26%. So that's significant, right? So making sure that you not only have an experienced team surgeon, but also programmer, all those things are important.
You use the term, at a center. I think you said that once or twice. And I just want to make sure I understand this right and that our audience understands this right. There are places where the movement disorder specialist that you might see is a part of the same group and they work very closely with the neurosurgeon that you might work with in terms of having your DBS surgery. But that's not always the case.
That's correct. And then it can be multiple ways. In fact, so for my practice, I would say about half to maybe a little more than half come from our internal movement disorder specialist, part of our, comprehensive Parkinson's and movement disorder center. And everything is encapsulated within that. So that's the way I typically think of that. But that being said, almost half of my patients come from outside neurologists that don't have a in-house surgeon.
Yeah, so this can go well either way, right? I just want to make sure that nobody hears this conversation and thinks, oh, I just learned that I really need to go to a center that's entirely comprehensive, and if I don't have that, it's
Right.
not necessarily going to go well for me. But
Right.
it couldn't work well either way, whether it's connected or not.
Absolutely. And if you look at the numbers, about the I'd say about half of DBS in the country right now is actually done outside of centers. And there's nothing to show that they do worse than ones that are treated at centers, right? So I wouldn't have that be a barrier to saying, oh, I'm going to consider this option.
Okay, great. Thanks. Let's dive into some more sort of specific questions, and let's start with surgery, awake or asleep. Can you just tell me generally about this? Is there a difference? What do people need to know about this choice? And I say awake and asleep. I know those aren't necessarily the
Yeah. No,
technical
that's
terms here, but you know what I mean. So can you just describe this and what
yeah,
this
yeah.
means and go into this a little?
I think that's fine, right? So I am, for the record, exceedingly biased in saying that a sleep DBS is great and probably the best way to do things. And that bias has been imparted by the people I train with, Dr. Burchell at OHSU, Dr. Marwan Hariz out in Queen Square. They're big advocates of, you know, what is known as a sleep DBS, what we will call image guided, image verified DBS. A decade or so ago, this was always the debate. You'd always see a session debate, awake versus asleep. And those have died off. And that's largely because there's been data now to show that outcomes are comparable either way. There's some series that show that you have maybe a marginal improvement, increased improvement with awake, and vice versa, increased improvement with asleep, and things are better here and there. I think ultimately what we've all come to agree on as a community is that these procedures are inherently different and require different skill sets. Doing awake DBS usually involves microelectrode recordings, intraoperative testing. So coming back to this idea of teams and the whole idea of what that workflow is, you have to have an anesthesia team that is comfortable doing the procedure awake. You have to have a neurosurgeon that's well versed in interpretation of microelectrode recordings, or a neurologist that's going to be in the operating room interpreting that, as well as intraoperative testing. Versus on the sleep DBS side, it's all image based and it relies heavily on preoperative and intraoperative imaging. That's why we can do it now and we couldn't do it at the inception of DBS. Imaging capabilities weren't ready at the time when DBS was being introduced in the 80s. So, the skill set changes drastically to a firm understanding of imaging, how to optimize imaging, how to interpret the imaging versus how to interpret the neurophysiology. So, as long as your surgeon and team are comfortable and well versed in that particular skill set, I think all this is where we come to outcomes are ultimately the same. Now, if you force a primarily awake surgeon to do a sleep or vice versa, that's where I think you might see slight differences, right?
It sounds like maybe one part of your answer would be that a person should be comfortable with whatever type of surgery they're going to experience as the patient. And then the second question is, you know, is the surgeon that you're going to see the right surgeon for the type of surgery that you are more comfortable with and that you think is the right fit for you, and what your movement disorder specialist or neurologist and what the rest of the team thinks is the right option for you. But there's two
Correct.
parts of the equation that first of all, the person may have a preference because maybe they don't want the anxiety of being awake, for example. What factors do you think are worth considering if you're trying to decide which procedure as a patient you want to experience?
Just off the bat, so we ran this survey of our movement disorder patients years ago, and you know, when we brought up, would you prefer awake versus asleep surgery, the large majority would say, I'd rather be asleep and not awake during that whole process, right? Certainly, someone that is older might not tolerate anesthesia well. I still remember um, multiple instances in my training where you had a older patient getting DBS and we were trying to do it awake and the initial induction anesthesia hits them harder and you're trying to wake them up and you're saying, Mr. Smith, wake up, and they're still sleeping and so then you're limited in your wake testing and so you're like, okay, how much can we rely on intraoperative testing? You can still get the recordings, but you've kind of lost one arm of your testing, which is, again, fully biased, is on the sleep standpoint, much more repeatable, much more reliable, right? Um, there's an anxiety component to it. I also do focused ultrasound for tremor. And I think one thing I make sure to talk about, because that procedure is always awake, is that are you going to have anxiety being put in a frame to hold your head in place? And you're going to be in this enclosed setting. Is that okay? So, psychologically, if that's, I have no problem with that, then fine. right? If that is a deal breaker, then okay, I'd rather someone consider a sleep DBS rather than say, no, I'm not getting it because I have to be awake.
There's also stimulation locations. Can you talk
Yeah.
about the difference between them and why someone might choose one location over another? And if if surgeon choice or surgical team is a factor in that?
Yeah. So I would say that, you don't really choose the target chooses you, right? So,
And what are the
all
targets?
to, yeah. So there are three main targets for Parkinson's. Two of them, subthalamic nucleus or STN, and the globus pallidus, pars interna, GPI, treat all the major symptoms that we think out, the cardinal symptoms, tremor, stiffness, bradykinesia, dyskinesia, dystonia, um, and rigidity. So they treat those symptoms equally well. There's a fallacy that is one of my crusades to stop about STN being a tremor target. It's not true. There's plenty of people and studies to show that patients with palatal stimulation and GPI have as good tremor control, but the time course improvement is different. GPI tends to take longer, so that if you compare patients at 1 month with both targets, the STN patients may seem better off, but at 6 months plus, they're the same. And multiple randomized controlled trials have shown that long-term outcomes, which I would argue matters more, are comparable for both of them. Now, there are nuances between the two, and the key distinctions are that the STN will reliably reduce medications more. So if someone's on a high dose of medications or has a desire to reduce medications, that might push you towards the STN target. Symptoms like dyskinesia, dystonia tend to respond a little bit better to GPI. So if you have those as predominant symptoms, you might get pushed more towards the GPI target. And then from a risk standpoint, if there are pre-existing gait problems, mood problems, cognition problems, the SCN target may be a little bit higher of a risk than the GPI target. So the GPI is a little bit more forgiving in that sense. So there are definitely pros and cons to each. Um, and so that's why I kind of started with the target kind of chooses you. And this is a discussion that we have again in our center. We would do this as part of a formal discussion when I am planning for outside neurologists. It's a phone call or a series of email messages to say, okay, what's the best target for this patient? The third target that I didn't talk about yet is the motor thalamus, otherwise known as the VIM, and that only treats tremor, doesn't treat the other symptoms of, rigidity, bradykinesia, dystonia, etc. And so if you are only bothered by the tremor, that may be a better target, which is why, in the setting of focused ultrasound, that's the target that's being used equally for essential tremor and tremor predominant Parkinson's disease. And the reason we might go there is that if, again, like I said, if tremor is the only concern, and if there is some other reason where you might not need or need improvement of the other symptoms, then the VIM target can also be even less risky in terms of potential side effects. So there's all these different things. What I've just talked about scratches the surface a little bit, but it's a extensive discussion in terms of figuring out for that individual which of those three are the best.
So, can you talk a little bit about the differences between the devices that are available? And I guess we'll limit this just to devices that are available in the US because there may be differences
Right,
elsewhere. So,
right.
maybe just the ones that are available in the United States, since that's where the Davis Phinney Foundation is based.
Okay.
It'd be great to hear what you think about the different devices and maybe what people should consider about the differences.
In the United States, there are now three FDA approved devices for deep brain stimulation. Medtronic was a device that has been out for decades, and then more recently, the Abbott device was approved, and then the Boston Scientific device. Ultimately, this has been good for patients, everybody involved, because competition drives innovation and change. And, what I'll start with is that there are certainly no head-to-head comparison studies between the three devices. I don't think there ever will be. No one's going to volunteer to run a study that compares all three in terms of outcomes. But From the data we have, there's no significant difference in overall long-term outcomes with any of the devices. So all of them will do the job. The analogy I always have is that, if it's like a car, they're all going to get you from point A to point B and do it very safely and do it very efficiently. It's the bells and whistles. It's like choosing between a Mercedes and a BMW. Some people are just Mercedes people, and some people are just BMW people, right? So it becomes these features, not outcomes that are different. So when we talk about the features, the things that we talk about, that I talk about with patients primarily are uh, battery size, the patient remote and the interface, and battery longevity, how long a battery will last. Now, aside from that, all three companies have pretty similar hardware. They all have what we call segmented electrodes that allow the neurologist to adjust the stimulation in a more refined way than we had in the past. They all have both rechargeable and non-rechargeable options for the implantable pulse generator. Um, but then you kind of get into where are the true differences, right? So when we talk about battery size, that's largely going to be driven by if you choose a rechargeable versus non-rechargeable. And that's an option that I typically give my patients because it's a lifestyle decision. I give the option, and surprisingly, it's a fairly even split, although maybe a little bit more leaning towards the rechargeable these days. The rechargeable tends to be smaller because it only has to hold a charge for weeks at a time. A non-rechargeable will have to hold charge for years at a time, so it's inherently larger. When I present the options to patients, I have some that say, why would I want to have to recharge my battery on a weekly or bi-weekly basis? I just want to leave it alone. And others that say, why would I want to have my battery changed every, 4 years, 5 years? I'd rather have a battery changed every 10 or 15 years, right? So
So
it's
can you
pure
say which,
preference.
sorry to interrupt again. I just want to make sure I don't lose track of this because I think it's an important question that people have. Is there a, let me think about how I want to put this. Is there a difference in terms of how long a battery lasts? Like if I get a rechargeable battery, is it always going to be a longer lifespan of that battery or pulse generator than the sort of non-rechargeable?
Correct, correct. Now, there's no large significance between the different manufacturers. There's some testing that might show that some non-rechargeables last longer than others between manufacturers. That's been primarily bench lab testing, not real world outcomes. So it's hard to really decipher what that really means. But yes, the general rule is the non-rechargeable will be in general 3 to 5 years before it has to be replaced. The rechargeable tends to be 10, 15 years before it has to be replaced.
Right.
You have
That's
to take care of it. You have to charge it, right? Because I've had folks that don't recharge it, then they, tax the battery, and then that ends up not holding a charge and has to be changed sooner. So again, if charging fits your lifestyle and it's not something that you're going to become overly anxious about, because that's a factor I actually didn't consider until I've had some patients think about it, is that what I do want to emphasize is that charging a medical device is not the same thing as charging your phone or anything else. Because people kind of come into it saying, "Oh, I charge all sorts of stuff. This is going to be easy." For some patients, having that responsibility of thinking, if I don't charge it, all my symptoms are going to raise anxiety that make it more, like, add another layer to it, right? So I used to, I think, downplay the recharging. I think it's something that, there are plenty of videos online to watch of what that involves. I think it's important to understand what that truly means before you commit to that.
sure.
But yeah, I think getting back to my thoughts on, the different devices, if we peel into kind of what are the main differentiators between the three, the Medtronic device is the only device that is currently able to record from the brain. So it has sensing, as they call it, and they recently got approved for adaptive DBS, or what's called ADBS. And because it can sense, the idea is that it can then close the loop and automatically adjust the stimulation based off of the recordings that are being obtained in real time. So if your brain is saying you don't need as much stimulation, it's going to lower it. And if it says you're going to need more stimulation, it will raise it, and it changes throughout time. And that has been shown to increase some of the, or decrease the off times that people have and extend the amount of control across a day that patients have. This is a very, I would say this technology is certainly in its infancy and there's more to come from it, but it's literally this year that this has now been really commercially available. The Abbott device, some key features with the Abbott device, they're the only ones that have the capability for remote programming. So if, getting to your movement disorder neurologist is difficult, and we used to think about it of, oh, if someone lives far away, then remote program might be better. And that's not even necessarily the case because, there are definitely folks that even though they live close, just the act of getting into a car, getting to the neurologist, or getting a family member to take them there makes it more difficult. So is remote programming something that you think that you will leverage? And Abbott is the only one that's gotten that cleared and it's FDA approved, and there's multiple securities um, uh, in place to make sure that this happens safely. But just like you would log on to a telemedicine type visit, you can do that with your neurologist. You have to give them access to access your you have to give them the ability to access your device. You turn that option on, they can then access it and they can make adjustments remotely. So if you need it checked or adjusted, that can happen through a telemedicine type visit, which is certainly a nice feature. Their rechargeable device is technically the smallest on the market, although it's fractions of a cubic centimeter smaller than the Medtronic device. Those two are probably the smallest rechargeable devices. And the other main differentiator for Abbott is they've done a good job partnering with Apple to make things easy on the controller standpoint, so that you don't have to have an additional controller if you don't want to. If you have an Apple device, your programmer can be put directly onto your phone, so that you can check your device, make any adjustments that you might need to do without carrying something extra. And they've also now recently extended that to Android devices. And then Boston Scientific has done a lot of work with something called visual programming and fine-tune adjustment of their stimulation. So they probably have the most stimulation options available. And in order to make sense of all those different options, I think kind of the analogy I have there is like sometimes you go to a restaurant with a ton of different menu options. You're flipping through pages and you can't really make a decision because it's process by analysis. But to make sense of that, they have visual programming, which the other companies don't, where the neurologists can see a representation of what the stimulation might look like in your brain to make fine-tune adjustments of the stimulation there. So again, these are all different features, but those are kind of the key differences between the three manufacturers.
I guess I want to close this part of the pre-surgery conversation by asking you, you know, so say I've decided on with my team, we've all come to agreement about what location we're going to use and where the surgery is going to happen, and the team's all set. What else should a person with Parkinson's do in preparation for surgery? Maybe on the scale of, what about if it's 2 months out, what should I be doing? If it's 2 weeks out, what should I be doing? If it's days before the surgery, what should I be doing?
Yeah. I think my initial message would be to not overthink this, because, um, you know, the way I'm going to frame this is that DBS surgery is a very different entity today than it was in the 90s, in the 2000s. And there's more and more papers coming out to kind of show that. DBS surgery is safer and more efficient, certainly, than in the past. And even in my career, I remember uh, before bringing patients into the hospital the night before. holding their medications, because that's another distinction coming back to the awake versus asleep. Those that if you have awake surgery, usually you have to come off of medications to exaggerate your symptoms. The sleep surgery, patients take medications up to the surgery because we don't need to see you at your worst. But I remember admitting patients before and then doing the procedure, and it might be staged, and then they go to rehab afterwards. Uniformly, this was how it was done. And today, I would say 99% of patients go home before noon the next day. It's an overnight stay. There have been a handful of patients that have had it done same day, and there is experience that it's published on same day DBS that can be done safely. And then we actually recently did an analysis of national safety data, looking at millions of procedures, comparing the overall risk of DBS surgery to very common elective procedures. And the punchline is if you look at DBS relative to something like a knee replacement, which people are very commonly going to proceed with, DBS is a 3, 4 times lower risk than a knee replacement overall, right? But it's this idea that it's brain surgery, quote unquote, that makes it seem more daunting. But in reality, the overall risks are not as large, and the impact of the surgery from a kind of setting you back standpoint is not as significant. So in general, the I would say most patients resume regular activities within 2 weeks. I have some folks that would, you know, if I didn't give them that restraint, would probably do more sooner, right? But, you know, I think that to answer the initial question is that, general preparation would be how you approach any other elective overnight sort of procedure. Stay active, stay healthy. Don't go on a all night bender the night before. Probably not advised. Um, you know, just do your regular exercise, which is good for Parkinson's at any time, right? Um, and then beforehand, I think more important is just follow the instructions given by your surgical team. And it seems, uh,
It sounds easy,
these
but it's
are,
not,
it
right?
sounds easy, it's not, right? And if there's question and confusion, this is again why you have to be comfortable with the team. If they're not responsive, then that's an issue because, they're going to tell you, you know, what do they need to have done? What studies need to be done beforehand? What MR, making sure that you go to your MRI appointments, going to your pre-admission testing appointments, taking or not taking the medications that they tell you to take or not to take, what time to show up to different places, just being ready. And then if there's any uncertainty, communicate. And like I said, avoid overthinking it. And if you just kind of go by this, this uh, if you follow that path, you'll get to the end just fine.
So let's talk about post-surgery a little bit. You already talked about this a little bit, and
Mhm.
and I think you said 2 weeks to return maybe is what you tend to recommend in a general sense, but obviously individual circumstances may vary. Um, but so you said 2 weeks, but what about getting back to the full course of life? Like
Sure.
if I'm running a marathon in June, could I have a DBS surgery in May? Like what's the timeline before returning to rigorous activities? What do I need to know about that if I'm thinking about
Yeah.
DBS surgery
So,
recovery?
like you said, everybody's a little bit different, but general rules is that, first 2 weeks, be a little bit more cautious. Then 2 to 4 weeks is kind of proceed with caution, right? Gradually increase activity, see what, listen to your body. If you're doing too much, you'll know, right? But most people will be just fine. And I would say the majority of folks by 4 weeks, I say you can return to whatever, right? I say the only restrictions that you have is I'd recommend you not hitting your head against things, but that's good general advice.
Okay, so what about an immediate, I have surgery, I go home, it's the first week after surgery. Probably not, we're not lifting heavy items, probably we're going to be generally
Correct.
cautious, but is there anything else I should know about if I'm going to go home after DBS surgery? Like any medications if I have headache pain, am I not taking ibuprofen? Obviously there's going to be
Correct.
instructions you give me when I leave
Yeah,
your clinic, but
right.
is there anything that is important for people to be aware of generally?
Yeah. So surgeons are very simple people, and that the two things that are the bane of our existence are bleeding and infection. And this is going to be true for any surgeon, right? So these are the things that we are paranoid about and try to minimize and go through everything possible to do that. So from the bleeding standpoint, as you alluded to, if you were previously on blood thinners or things like that, that is something that we would have coordinated with your cardiologist or neurologist or whomever to come up with a plan of how we're going to manage those, blood thinners, whether it's a aspirin, Plavix, Eliquis, all the different antiplatelet medications that are out there, of stopping at some duration of time before and some duration of time after. So just continuing again with that developed plan. In that line, the more common things of if you have a headache, like you're asking, Tylenol is the answer here because aspirin and NSAIDs, so NSAIDs, big things being like Motrin, Aleve, uh, those can affect platelet function. And what we get concerned about is bleeding if that is started too early, right? And so your neurosurgeon will give you a time frame when you can take NSAIDs or aspirin. But if in the meantime, Tylenol is the go-to, and that usually covers most patients. Um, the other aspect of infection, we go through all the pains of doing the procedure under with sterile technique and minimizing the risk from our standpoint. We need help on the back end, keeping those incisions clean and dry. Um, Again, things that I shouldn't have to say, but do because I've seen them. Please don't poke at your incisions. Please don't pick at them. Please don't pull off scabs. These are things that I continue to see. So I have to say it.
Yeah.
So the main thing is keep those incisions clean and dry, clean and dry. The hard part is that the incisions on the head when you start washing your hair, you know, I think it's important to actually clean them because people get afraid of getting close to them. And then so they build up all this, for lack of a better word, gunk around the incisions, and that doesn't help. And if you do clean them, make sure they get patted dry, especially if your surgeon does a minimal hair shave. And for female patients, you might have a mass of hair around there. You don't want that moisture around the incision. That's going to not be helpful for wound healing, also potentially risk infection. So clean and dry. That's the key.
Okay, so I would add maybe another thing. Tell me, it sounds like a lot of your advice in this regard is follow the instructions that your team provides you because you may have individual circumstances. But generally speaking, it doesn't sound like your view as the surgeon is that the surgical recovery is particularly complex compared to other surgical recoveries that you might
Right,
have, like a
right.
knee replacement.
Yeah, and it's all relative, right? As a neurosurgeon, like I said, I do a lot of deep brain stimulation surgery. I do a lot of epilepsy surgery, and it's a very different recovery, right? So, in the realm of what we do, yeah, it's a pretty straightforward procedure. And yeah, there's some, I would say on the longer end, might take, you know, 2 months or so. But we rarely see folks that, months out are still recovering from their DBS.
As we wrap up, I guess I just want to ask if there's anything I didn't ask or anything that you think we didn't talk about that people with Parkinson should know about how to get the best outcomes from their surgery if they're having DBS.
Afterwards, having early mobility, those that are a little bit more motivated to kind of get back to their regular routine tend to inherently bounce back quicker, right? On a more granular level, I would say, you know, understanding what to expect with the hardware, because, having an implant uh, certainly is typically a new experience for most people. So you have to understand that, yes, you might feel bumps under your scalp, where the hardware is, a bump under the where the battery is. Again, everything is under the skin, but you'll feel it. And the fact these that these devices have gotten certainly smaller over time, but the fact that they're bigger than nothing means that you will feel it, right? So just being able to understand that the wire down the neck, the design has gotten better. Some people feel it less, but sometimes if it is bothersome, people will stop moving their neck. And that's probably one of the worst things you could do is because then the scar that inherently forms around the hardware will form in a shortened position, and then you might be a little restricted and feel it down the road. So kind of again, early mobility, turning your neck back and forth, walking around, all these things will help.
Just real quick, people sometimes ask me in emails and they reach out to ask, I don't, how can I move my neck too far? Like, do I have to be careful about my range of motion? Is that a concern? Not a concern.
It's not a concern with the devices these days. These are extremely robust. What I would say is that the wire that goes down the neck is designed in a way differently from the wire that goes into the brain because it is made to withstand those movements. So, um, you know, that's why I say going towards the side of early mobility to make sure that that flexibility is maintained.
Great.
The other thing that I think important part of what to expect after that we didn't talk about was, you know, yes, like I said, the idea is to make sure that is for DBS to let you do more. The one thing that you have to be aware of is that this is an implantable device and it's not like a hip or a knee, right? It's not an inactive, it's an active stimulator, right? So think of it like a mini computer. Because it is like a mini computer, it is subject to potential interference with large magnetic fields, what we call EMI or electromagnetic interference. And in your day to day, that is not, you don't stand or are around by large enough magnetic fields for that to be a major concern. Um, the most common scenarios are going to be security systems. So TSA, airports, courthouses, things like that. Um, we recommend that I'm probably overly conservative, but in my mind, I'd rather be that way. I'd say don't walk through the systems. Don't get wanded. In fact, wanding poses a bigger issue because if they wand directly over the battery, that's actually more magnetic energy over the device than a general field. Um, because it could do one of a few things. It could turn off the device. It could apply extra stimulation. It could uh, render the device completely inactive. And the likelihood of those things happening is low, single digit percentiles. But what I will always say is that if you want to make it zero, then don't expose yourself to that, right? Be an advocate for yourself. TSA and airport security are usually they're very familiar with these devices. So most of my patients don't have issues there. It's kind of the other security systems, like if you go to a sporting event, music event, festival, you have potentially security personnel that don't do it on a regular basis, and it may not be as familiar. So just be aware that that's probably the most common scenario where you might run into electromagnetic interference. And then on that same note, understanding MRIs, the devices are what is called MRI conditional, meaning that if the right conditions are met, you can get an MRI. So the devices will have to go into MRI specific mode. You'll have to let the radiologist or whomever is ordering it know that you have the device. You will usually get a card with the details of what has been implanted, and then they can use that card to determine the parameters under which to get the MRI. So those are the main, I would say, restrictions of this device, just understanding that, security systems, MRIs shouldn't be standing by large transformers or, large magnetic fields because that could cause an issue with it. But day-to-day stuff like, cell phones, microwave, etc., that's not going to really do anything.
Dr. Wu, I think you've shared so much great information with us, and I'm really grateful for your time. And I hope that in the future we can connect again to talk more about some of
Sure.
the nuances here.
Absolutely. It's my pleasure.